My name is Jennifer Valdez, and this is my case study presentation over medical weight management and weight loss medications. Here is the outline of this presentation. First, we're going to talk about the Center for Obesity and Metabolic Surgery clinic site. We're also going to talk about obesity, some background information, as well as some current statistics. We're going to discuss weight loss and weight maintenance. We will begin to discuss the case study patient, her background information, the assessments, interventions, and treatments that were given to her. We're going to discuss two weight loss medications, phentermine and topiramate, as well as a summary and conclusion slide and discussion points. The Center of Obesity and Metabolic Surgery offers a medical weight program that is led by a multidisciplinary team of healthcare professionals that include psychological. According to the National Institute of Health, a patient must have a BMI of at least 40, or if they have a BMI in between 35 to 40, they must have presence of serious comorbidities. Other factors include a willingness to adhere to a lifelong modification through daily diet and exercise, psychological stability, and the existence of an effective social support system. They must also have a history of attempts to lose weight by dietary and lifestyle modifications. Obesity is a complex, multifaceted disease. It causes multiple medical and physiological and functional complications that reduce life expectancy and impair overall quality of life. Weight loss and weight maintenance is difficult, especially in an obesogenic environment where there is access to unhealthy foods, along with genetics, biological, behavioral, and cognitive factors. Here is a picture of all the comorbidities that are associated with obesity. A recent 2015 review from the Journal of Metabolism found that among overweight adults who achieved 10% weight loss, only 50% of these adults were maintaining this loss for over a year. A 2016 meta analysis showed that over the last 5 years, 42% of adults reported that they were trying to lose weight, and 23% of adults reported that they were trying to maintain weight. Here is a figure of all the factors that are associated with weight maintenance. As you can see at the top, face-to-face intervention, personality traits on the right, health concerns, the patient's satisfaction with their results, as well as their self-confidence about losing weight without help, eating breakfast regularly, low-calorie diets, physical activity, and weight loss drugs. Strategies for weight control include diet modifications, physical activity, self-monitoring, and social support. What's proven to be the most effective model for treatment of obesity is a longitudinal multidisciplinary approach, which includes a strong patient and physician and dietitian relationship. This can also be enhanced with weight loss medications. Studies have shown that patients who receive face-to-face and monthly visits and follow-ups with providers have improved sustained weight loss and exhibit less weight gain. Here is a chart over the effectiveness of different weight reduction means. On the left, you can see the different interventions that were used, and on the right is the resulted weight loss. RWL stands for relative weight loss. This just means their weight loss from their initial body weight. So when nutritional therapy, physical activity, or behavioral therapy was given as a single intervention, there was about a 5% relative weight loss. When a multidisciplinary therapy intervention was given over the span of 6 months, there was an increased weight loss, about 5 to 10% of relative weight loss. When a multidisciplinary therapy and usage of a formula diet was given for 12 weeks, there was increased weight loss 15 to 26%. And bariatric surgery has the most weight loss with about 20 to 40% of the relative weight loss. Assessment for obesity includes categories of patient's histories, physical examination, laboratory tests, as well as a need to assess for sleep apnea and cardiovascular risk. So with the patient's history, the physician or dietitian should look at the patient's weight history, previous efforts to lose weight, physical activity, their eating habits as well as their quality of diet, psychosocial performance, family history, and any substance abuse history. Their actual current body weight should also be measured, as well as their height, waist circumference, their general appearance, blood pressure, and if it's available and feasible, a bioelectrical impedance analysis or ultrasounds of organs such as the liver. For laboratory tests, measure their fasting plasma glucose, the hemoglobin A1C, lipid panel, blood count, as well as their vitamin and mineral levels, as well as hormones such as somatic hormones and their sex hormones. According to the World Health Organization, obesity can be divided into three classes. Class 1 is a BMI between 30 and 34.9. Class 2 is a BMI between 35 and 39.9. Class 3 is a BMI over 40. Now we're going to talk about our case study patient. Our patient was a 41-year-old Caucasian white female with morbid obesity who first presented to the Center for Obesity and Metabolic Surgery on January 21, 2016 for medical management. She had a total of 10 visits with the doctor and with the dietitian. These visits occurred monthly and occurred on the same day. Here's some background information on the patient. She reported at age 18 her weight was 180 pounds. She also reported 45-pound weight gain over the past 5 years, with her highest reported weight being 296 pounds. Previous weight loss attempts include Weight Watchers, low-calorie diets, and exercise programs. She also reports a history of emotional and stress eating as well as overeating. Comorbidities include osteoarthritis, weight bearing of the knee, as well as fatigue. No major psychiatric diagnosis, however, she did report a history of anxiety and depression. This patient provided a social history of being employed as a full-time research coordinator, married, and is a mother of 3 children, one with special needs. She reports never smoking, rare alcohol usage. Her medical history includes an episode of eclampsia in 2007. Family history on her mother's side, her mother had COPD, asthma, hypertension, and high cholesterol. Her father had hypertension and obstructive sleep apnea. Surgical history includes gallbladder removal in 2000 and a C-section and tubal ligation in 2007. On January 21st, this patient weighed 292 pounds and had a height of 67 inches. Her ideal body weight at a BMI of 25 is 159 pounds. So with her current weight, she was 184% over her ideal body weight. Her BMI was 45.3, which is classified as morbid obesity or class 3 obesity. Here are her baseline labs on January 21st. As you can see, cholesterol was low as well as her vitamin D levels. Baseline medications include an allergy medication, a multivitamin, and an antibiotic. For her physical assessment, she reports positive for fatigue as well as joint pain. Her physical exam was within normal limits. When they examined her abdomen, extremities, skin, and lungs, everything was reported to be within normal limits as well. From her initial nutrition assessment on the 21st of January, she reports that main weight gain came from emotional eating with son's diagnosis of autism, as well as pregnancy and marital issues. Her previous eating habits include consuming cereal for breakfast, fried fatty foods for lunch, and her estimated caloric intake was over 2,000 calories per day. She did report that she has made dietary changes since December 2015, and this was done by her portioning and measuring food out. She was also reported that she was tracking calories via her phone app, which her budget was set to 1440 calories per day. However, she was consuming calories burned through exercise that was increasing her budget in her app. Her 24-hour diet recall indicates that she was consuming 3 meals per day with some snacks in between, which you can see these are processed high carbohydrate snacks. Her estimated calories were around 1900 calories per day, relatively high protein intake, about 99 grams. Her carbohydrate was 42% of her total calories, and fat intake was 37% of her total calories. So while 1900 calories per day is not an excessive amount for a woman, a 41-year-old woman who is relatively inactive and trying to lose weight, 1900 calories is too high of an amount to induce any type of weight loss. For her diet recall, the patient reported that this had been normal for her, this type of eating, since making those changes. She reports that she was trying to eat more frequently at home, avoid liquid calories such as sodas and juice and alcohol. She did report to have over 64 fluid ounces per day and snacking due to hunger. Patient reports that she was not currently exercising. She was getting about 7,000 steps daily, non-planned physical activity. This was just her walking throughout the day. Usual activity is mostly sedentary for her, and she reported that her barriers to activity include time management. The nutrition diagnosis that was given to this patient at the time was morbidly obese female related to history of emotional eating, lack of food planning, and sedentary lifestyle, as evidenced by a BMI over 40 and history of weight gain. So when estimating her needs for weight loss, the equation that was used was the 11 to 14 calories per kilogram based on their current weight, which her current weight was 133 kilograms. That gave her a caloric range between 1460 to 1862 calories per day. Now, the 11 to 14 calories per kilogram current weight equation is also based on the Aspen guidelines for non-critically ill obese patients for weight loss. The macronutrient division is standard, about 50% from carbohydrates, 20% from protein, 30% from fat, and her fluid intake is going to be over 64 ounces per day. The caloric prescription that was given to this patient was 1,500 calories per day based on estimated energy needs for weight loss. This is near the lower end of the range from the previous slide. We also educated the patient on basic weight management principles that include knowing the caloric needs for weight loss, label reading, portion sizes, healthy food choices, structured eating plan, as well as self-monitoring and exercise. The patient was also given goals to begin regular exercise at least one time per week by walking, plate method for lunch and dinner, and to start a multivitamin with iron. For monitoring and evaluation, we're going to monitor their weight changes at each visit, as this can be very indicative to see if the patient is adhering to their caloric prescription diet. Also, with them tracking and logging their foods, by them doing so, we can evaluate their diet and their exercise records at each visit and identify areas for improvement and offer feedback. We can also we also are going to evaluate the patient's progress with behavioral goals at each visit. The next visit was on February 18th. She weighed 291 pounds at that visit, which was only a 1 pound weight loss since the previous visit in January. Here are some quotes from the nutrition note. She's consuming 3 regular meals per day with some snacks during the daytime. Her food diary indicated that her caloric intake was between 12,000 to 1,800 calories per day. She reported to not be planning her meals ahead, but did achieve the walking one time per week, 40 to 45 minutes per session. The diagnosis that was given to her at the time was intentional weight loss related to increased energy expenditure, as evidenced by a weight loss of 1 pound since last visit. The intervention that was given to her was to modify her to a 1,400 calorie diet, which was 100 calories less from her previous prescription, and also to reinforce the basic weight management principles, and also the same as the previous nutrition monitoring and evaluation, which includes evaluating their weight as well as their food logs. Some goals that were given to the patient to practice for the next visit included planning dinner meals ahead at least 3 nights per week, to record anticipated lunch and dinner intake after breakfast to improve commitment to her meal plan, and to log intake more accurately. On that same visit, this patient was also placed on 2 weight loss medications, phentermine and topiramate. Now we're going to talk briefly about weight loss medications. The function of weight loss medications is to aid in producing an energy deficit and provide reinforcement to continuing changed eating behaviors. An anti-obesity drug review from the year 2014 found that with the use of an anti-obesity drug, when compared with placebo, it improved weight loss maintenance by about 3.5 kilograms. Weight loss medications should be prescribed only after there is an extensive discussion of risk and benefits between the patient and physician. For this patient, an EKG was ordered on February 18th, and the results were normal. Weight loss medications need to be taken in conjunction to a reduced calorie diet with increased physical activity for optimal chronic weight management in adults with an initial BMI of either 30 and above, which is considered or classified as obese, or if they are between their BMIs in between 27 and 30, they must have at least one weight-related comorbidity. Here is some background information on phentermine. The mechanism of action is that it works as an appetite suppressant. Contraindications include advanced atherosclerosis, cardiovascular risk, moderate to severe hypertension, hyperthyroidism, glaucoma, agitation, substance abuse history. So this case study patient had none of these conditions, so it was appropriate for her to be placed on this medication. However, phentermine is not approved for long-term use as there is no long-term data on its safety or efficacy. Weight regain is likely to occur once medication is stopped. However, currently it is the most widely prescribed weight loss medication. This may be due to the relatively low cost of phentermine compared to other weight loss medications, and it may likely be highly prescribed by clinicians due to the minimal reports of serious side effects, even without the data of long-term safety and efficacy. Phentermine at the dosage of 15 milligrams alone was shown to induce 7% weight loss at 6 months. Patients should be informed that it is not FDA approved for long-term use and has not been documented to be safe or effective. Topiramate is the other weight loss medication that this patient was placed on. Its mechanism of action is unclear, but its effects may be due to increased satiety and acting as appetite suppression. Contraindications include hypersensitivity to any product ingredient. Topiramate increases the risk of birth defects. It should not be given to women who are pregnant or may become pregnant. If you can recall, this patient received a tubal ligation in 2007, so it was appropriate for this patient to be placed on topiramate. So evaluating effectiveness in weight loss medications is done by assessing the weight loss after 3 to 4 months that the patient has been placed on the medication, and there must be at least 3 to 5% loss of their initial body weight in order to determine its effectiveness in the individual. If there is not at least a 3 to 5% weight loss, it's recommended to discontinue the medication. Doing so will decrease the patient's exposure to the risk and cost of drug treatment when there is a low probability of effectiveness and a long-term benefit. Now we're going to return to the case study patient. Here is a chart that I made listing her subsequent visits after those 2 visits in January and March. As you can see on the very left is a date of her visits starting from March until November 17th, which was her most recent visit. And they occur monthly except for the month of July. And the next column is her weight that was recorded at each visit, as well as how many pounds she lost since the previous visit the month before. There's also a percent weight loss column. Her BMI is also shown, as well as a reported caloric intake that she gave or was averaged in her notes at each assessment. I also included her reported physical activity, as this can show background information and give context on the amount of weight loss at each month. During the summertime, it appears that she was more active. I also included a column over any medicine changes, whether if there was an increase in the dosage of the weight loss medications, I included that, and then any relevant comments. So on the 24th of June, you can see that she had only lost 1 pound since the month before. Some comments that she mentioned during that assessment was that she was hungrier, she was consuming larger portion sizes, and there was lack of self-monitoring or meal planning. On October 14th, they changed the topiramate dosage to 50 milligrams 2 times in the evening and 25 milligrams 1 time in the morning. On the very last visit, November 17th, at the very bottom, you can see that for the first time in the whole time she had been coming to the clinic, she exhibited weight gain, about 3 pounds since a month before. She also reports in the comments section that she had stopped taking phentermine and that there was frequent eating out. Here is a graph of her weight trend over the past 9 months. Now, this is starting from the very first visit when she was placed on the weight loss medications, which was February 18th, to the most recent visit, which was November 17th. On the left axis is the weight, and on the bottom axis is the date of the appointments. So February 18th, she started out about 291 pounds for baseline during the first visit she was placed on weight loss medications. And then it's starting to trend down, and I also included in the red arrows when there was changes in her medications. So pretty steady weight loss over the 9 months that she has been or had been on the weight loss medications. So the most recent visit was on November 17th. Her weight at the visit was 258 pounds, which was an increase of 3 pounds since the last visit. Her ideal body weight, she was currently at 162% of her ideal body weight, and her BMI was 40.5, which is classified as class 3 obesity. The medications that she was prescribed were the phentermine 15 milligrams 1 time per day, topiramate 1 a.m. tablet 25 milligrams, and 2 p.m. tablets 50 milligrams each, as well as a vitamin D and a multivitamin. Here are her laboratory values for November 21st. As you can see, calcium was low, as well as her cholesterol. Some quotes from the nutrition assessment on November 17th. Patient reports that she is retaining some fluid due to menstrual cycle irregularity. She never took her phentermine, but did report continuing her topiramate. She did report to be looking up her calories online and using a Weight Watchers book as a guide. However, she was not keeping a food log. She reported to be feeling overwhelmed with the work and home life and struggled to have time and regularity of her food choices. Her 24-hour diet recall indicates that she was consuming less than 1,000 calories with a pretty moderate amount of protein, 71 grams per day. So a large difference, huge difference from her initial 24-hour diet recall, lot less amount of food in her portions, and it looks like there's less carbohydrates that she's consuming compared to the initial 24-hour diet recall. The diagnosis that was given to her by the dietitian was involuntary waking, possibly related to fluid gain, as evidenced by waking of 3 pounds since last visit and reported physical symptoms of fluid retention. Another alternative PES statement is involuntary weight gain related to lack of consistent meal planning and self-monitoring, as evidenced by patient report and weight gain of 3 pounds since last visit. The interventions that were given to her by the dietitian included to record diet at least twice per week. That should include a weekend day and a weekday. Some interventions that I also suggested would to also continue with increasing the self-monitoring by regularly weighing herself at least 1 time per week, and to log foods minimum 3 times per week. Also to discuss with her healthcare provider regarding her discontinued usage of phentermine, and to meal plan and prep at the beginning of the work week for better adherence to her prescription caloric diet. For the monitoring and evaluation, it would be the same as previous monitoring and evaluation methods, monitoring their weight changes as well as assessing their diet logs. And from there, we can identify areas for improvement and offer constructive feedback. Her overall weight loss since January 21st, 2016 was 33 pounds. She also decreased about 22% of her ideal body weight. If you can remember, she started out about 184% of an ideal body weight, and now she's at about 162%. Her BMI also dropped 5 points since baseline, and she no longer complained of knee pain, and as a result was able to be more physically active. In conclusion, weight loss medications produced significant weight loss in the patient without any reported serious side effects or adverse events. It resulted in 11.6 weight loss over the span of 9 months. Now, this 9 months is from the February visit to the most recent November visit, in conjunction to a lifestyle change that included reduced caloric intake, diet changes, increased physical activity, all under the coordination and supervision of a multidisciplinary team. What are the next available treatments for this patient? Does she qualify for bariatric surgery? Or is she even interested in bariatric surgery? This can also depend on her financial capabilities as well as what her insurance covers and offers. If she wanted to look into something that is non-invasive surgical option for weight loss, this the Center for Obesity and Metabolic Surgery also offers the V-Block, which is non-invasive and proven to be safe for weight maintenance and weight loss, as well as a gastric balloon. Also, is the patient going to continue these lifestyle changes that include compliance to a lower calorie diet as well as increased physical activity? Typically, patients spend about 9 to 12 months in this medical weight management program, and then they tend to graduate out or they reduce the frequency of their visits. Sometimes they'll do quarterly visits instead of monthly visits. And for weight loss maintenance, is she going to continue her weight loss medications? Is she financially able to? Does she feel okay, feel healthy enough, or is any adverse events that may occur if she decides to continue this or discontinue would be something she would have to discuss with her healthcare provider. But we do know, based on trials of weight loss medications, that the weight loss effects of these medications are sustained only for as long as they are being taken.